My name's Luke Moore. I'm a consultant in infectious diseases, microbiology and virology in London in the UK. I spend maybe a couple of days a week healing the sick, at the end of the bed deciding upon which patients need what antimicrobials and what tests should be done. Then I spend 1 or 2 days a week in the laboratory processing patient samples, but also deciding upon which laboratory investigations best serve the patients in my area. And I spend another 1 or 2 days a week looking at academic research in the realm of antibiotic resistance and antimicrobial stewardship. One of the things which I'm really quite passionate about is how at the strategic level we as a global society are starting to address antibiotic resistance. We were kind of pushed by the World Health Organization maybe a decade ago now when they had a global action plan. We as the world must respond to this threat of antibiotic resistance. Inherent in that WHO Global Action Plan was the need for each of the member state countries, all 200-ish of us, to write our own national action plans about how each country wants to address antibiotic resistance. 3 years ago now, Asmita Chirani, myself and colleagues from around the world started to look at the extant national action plans. And you'd imagine if the WHO had asked all 200-ish member states to write theirs that 200 member states would have, but actually, as of then, only around 100 had. That analysis, published in Lancet Global Health, revealed lots of things, but one of the things which I really focused upon was only 100 of the 200 countries have written their national action plans. But only a quarter of those acknowledged that diagnostics had a valid role to play in trying to address antibiotic resistance. Fast forward to now, Georgia Lamb, myself and colleagues from around the world have done a deep dive into that, just about to be published in Clinical Infectious Diseases. Again, we pulled all of the extant national action plans, and fortunately more countries have now published theirs, good to see. But we zoomed in on how those countries, within their national action plans, have started to talk about, in more detail, how, where, and with what measurement diagnostics should be used to help us address antibiotic resistance. Cut to the chase, do read it, but cut to the chase. It's actually countries in the Africa WHO region and many low and middle income countries who are really trying to pin down their clinicians, their laboratories, on how diagnostics should be used to diagnose antibiotic resistance, to make patients' care better, and then what data we're collecting to prove that. So I think we all have something to learn from each other across the globe in how different countries are responding within their national action plans to the threat of AMR, and specifically how they're utilising diagnostics and how they're saying they're going to measure that use of diagnostics in helping to address AMR. And it's only through that cross-boundary learning that we can really kind of leap forward into how, where and for whom diagnostics have the best bang for their buck. When we're trying to get an understanding of where and for whom a diagnostic has the greatest impact, we need to make sure that where in that patient's journey that diagnostic is being rolled out is useful for the question we're clinically trying to answer for that patient, but then that we're constructively aligning where we're putting that diagnostic for that patient's journey with the data we're measuring. One of my hats, one of my sins is that I'm an editor for a journal, and so often there's good science being done, but that fails to constructively align the rollout of a new bit of kit, a new diagnostic test, with the right part of the patient journey, and then be measured for the right outcome. So that's really my plea, is that can we avoid that pitfall, first of all, in trying to get data to prove where diagnostics have their biggest bang for their buck. Pitfall number one. Pitfall number two is trying to run before you can walk. What we really need to be doing, wherever you practice, is taking an inventory of what diagnostic tests you currently have available to you, whether that meets the needs of the population you serve, whether those results are going back to people to actually action those results from those tests, or whether the results are going off into the ether. And then once you've taken that inventory, what's missing? What are you not offering? What are the gaps? And until you can decide whether what you've got is fit for purpose, what gaps there are, and what different bits of kit and diagnostic devices might fill those gaps, you're not going to be able to collect data and externalize it. So if problem number one is constructively align a bit of kit to the patients you serve, to the data you get out of that, pitfall number two is don't run before you can walk. Know what you've got in front of you and know what the gaps are. But there are opportunities around that, right? In doing that inventory, you might be able to decrease the amount of tests that you're doing. You might be able to do diagnostic stewardship and save money in one area, which you can usefully spend on patients and services in another area. So there are opportunities there. And being selfish for a moment, there's also an opportunity there if we can get our ducks all in a line, if we can constructively align the studies which you're doing where you practice and I'm doing where I practice, then that externalization of that data, that peer review, that publication means that you don't have to reinvent the wheel every time, because you can say, oh, this worked there and it worked there, so it might well work where I work. So there's efficiencies to be done there. So pitfalls and opportunities, but if we can understand them, then we can become more efficient as a healthcare society. Many of us who work in the clinical sphere understand to our core the value of a diagnostic test and the result it provides for a patient in front of us. We get that, we understand that value. A few moments ago, I talked about the national action plans at the other end of the spectrum, so not a one-on-one doctor-patient relationship, but the other end of the spectrum, what our governments expect from us as healthcare providers around addressing AMR, around the utility of diagnostics in doing that. But where is the government getting their data at that end of the spectrum? And at that zoomed in end of the spectrum, what are we not valuing beyond that just helping one patient at a time? How do we think about that valuation of a test beyond just its cost? So over the last year or so, the Office for Health Economics has worked with key opinion leaders, experts from around the world to try and come up with a framework to help us do that, to ascribe a value, or at least a framework for a value of a test beyond just its cost, that sits beyond just a one-on-one doctor-patient relationship, helps inform that, but also then punts data all the way up to government-level decisions, to policy-level decisions. And this OHE white paper is currently out for peer review, but the white paper ascribed this to be the STRIDES framework. And just to put you in the zone for what that is. So, yes, a result helps one patient. But that result can also affect the spectrum of the antibiotic which I have chosen to prescribe you. Can I narrow down that spectrum, polluting less of you, polluting less of your good bacteria? It can also impact the transmission of that pathogen from you to the patient in the bed next to you, from you to your loved one in your kitchen at home if it's a respiratory virus. It can also give us opportunities for our research. Go back to pre-pandemic. We didn't even know that SARS-CoV-2 was a thing. If we hadn't have had the right diagnostic test, we would have not been able to diagnose that as quickly. I is for insurance. If I just have one platform, one set of diagnostic tests, and it goes wrong, the company goes bust, the supply chain falls down, I've got a real problem. If I have platforms that interweave together, that are collaborative, that can run in parallel and synergize when one system goes down, then that's an insurance value, just having that pluripotency. D is for diversification. If I have a diagnostic test that gives me enough answers so that when I'm making a prescribing decision, I don't just have to prescribe the same thing again and again and again, and I can diversify my prescribing pattern, then there's a value there, right? Because that's going to have less existential pressure towards antimicrobial resistance. Then E is for enablement. So that's a funny one to conceptualize, but if you need surgery or if you need chemotherapy, then quite often you need antimicrobials to support that because you might get an infection as part of that. Sure, you might need an antimicrobial, but how do I know that antimicrobial A or antimicrobial B is going to be the thing that supports and enables that surgery or chemotherapy. So you need a diagnostic test for that. And the last one is something that we think perhaps as a global community we do realize the value of a diagnostic test for, and that's S is for surveillance. We all think that we generate a lot of data from our diagnostic test and say, oh, there's a problem here, there's a problem there, there's a problem with this bug or that bug. But do we? Do we leverage the full value from the tests we've already got to enable us to identify where problems are, identify what the solutions might be? And really only if you think about how a diagnostic test has extra value beyond just one person, across spectrum transmission, research, insurance, diversification, enablement and surveillance. Unless you ascribe value to that, you're not going to be able to convince the policymakers and reassure the governments who provide the healthcare resource that we're utilising diagnostics appropriately. I think many of us as healthcare professionals are very comfortable with the use of a diagnostic test and the results and how that impacts a patient. But as I alluded to earlier, the people that we need to convince are often not ourselves, because we're not the budget holders quite often, we're not the policy makers quite often. So although we have the knowledge, although we have the ability to ourselves as healthcare professionals on the shop floor evaluate a diagnostic, we need a framework, a way of communicating upwards to the budget holders and the policy makers. And that's really where the STRIDE framework, I think, can derive the most use for us all. And so if you're thinking of introducing a new test, evaluating the diagnostic platform for patients who you serve, then really you need to be thinking of not just the impact on one patient, but how it's going to be able to be numerated, and by that I mean collect data, please collect data around the impact on the spectrum of activity of the antibiotics, the transmission of that pathogen from patient A to patient B, the research for potential to enable us to cope with the next pandemic, the insurance value so that if one supply chain goes down because of a global catastrophe or conflict, we have resilience. The enablement for diversification in our prescribing patterns, so we're not just prescribing the same thing again and again. The enablement from that diagnostic test to allow surgery to go on, to allow chemotherapy to be undertaken, and the surveillance data so that we're taking those results from all of the tests we're doing and we're rolling it forward to the next generation, to the next set of patients who come in through our emergency departments. And if we, as a clinical academic community, can start to put data in each of those boxes, in each of those categories, through the STRIDE framework, then actually we can then speak up to the budget holders, up to the policy makers going forwards. So my plea really is to all of you, when you go to work tomorrow morning or whenever you're going to work, to start to think about the tests you've already got, the inventory of the tests you've already got. Do they marry up with the needs of the patients you serve? If they do, fantastic. But if they don't, how are you then going to do that gap analysis, identify the diagnostic tests which will fulfill that gap for you? And then what key performance indicators, what metrics can you, where you practice, start to put data into to help the rest of us understand whether your findings resonate with us? And then we might be able to start to get traction in globally addressing antimicrobial resistance.